talk about lupus. So let's get into it. So first of all, what is systemic lupus erythematosus? So lupus is a disease that is called the disease of 1,000 faces. And the reason being is that it's an autoimmune disease in which you have a lot of production of autoantibodies, but also of immune complex depositions, and it affects every organ in the body. So that's why it's called the disease of 1,000 faces, because in certain patients it could present in one way, but maybe the presentation is not going to be the same on other patients. A little bit about the history, because sometimes you wonder, why is it called lupus? So in the 13th century, one of the physicians, Rogerius, he thought that the skin lesions in lupus looked a lot like wolf bites or wolf scratches. So that was pretty common around that time, apparently. And that's why it stuck with the name. So let's talk a little bit about epidemiology. So it's said that 3.17 million of people worldwide are suffering with SLE. And here in the States, the prevalence is around like 20 to 150 case for every 100,000 cases. And then there was a recent meta-analysis that said that maybe like 73 for every 100,000 cases here. There's a female predisposition, and there are different theories of why this is. And one is because apparently there are several mutations allocated to the X chromosome. I think there are 4 that have been investigated. And there's a cool phenomenon called gene dosing. That means that the more X chromosomes you have, you actually get the luck to have a little bit more risk of developing SLE. And the same thing was actually noticed on patients that had Turner's, that since they only had one X chromosome, they had as much predisposition of developing SLE. But if you look at patients with Klinefelter syndrome, XXY, then they had heavier incidences of them, especially if they had the gene mutations that we talked about. The other thing is that there's epigenetic phenomena like imprinting and silencing. So what happens is that depending on the chromosome with the mutations, if these were silenced, you would or not develop the disease. But another thing about the female predisposition is that estrogens play a really good role on the developing of SLE. And it's because apparently estrogen stimulates a lot the B cells, maturations and proliferation. So whenever you think of SLE, try to think of women in reproductive age, 16 to 65. But the thing is that if men develop SLE, normally they have more severe cases with a lot of kidney involvement. Ethnicity, Hispanics, Asians, also Native Americans, Black African Americans, but also Black African Caribbean patients. So I like to go a little bit on the pathogenesis of this disease, because I feel like if you understand this part of it, you can actually understand all the antibodies that get to be part of the development of the disease, but also the different treatment mechanisms that now we are seeing nowadays. So guys, don't laugh. This is going to be my art, because I thought that this was going to be the best way to approach the pathogenesis. So what normally happens is that you have cells all around your body. Cells, when they get damaged, what happens is that normally they try to repair themselves. But if they don't repair themselves, what happens is programmed cell death. So through apoptosis, then what happens is that the macrophages and monocytes tend to clear them out effectively. But what happens if apoptosis is not happening the way it should? Especially with things that we see in SLE, like complement deficiencies, we are going to have an ineffective opsonization. And what happens here is that then there will remain parts of the nucleus, of the membrane cells, but also of the cytoplasm laying around. And all of those things actually then get in contact with your immune system, and they get targeted. So how does this happen? So If you see over here, these are the particles of the nucleus or cytoplasm, and then they get processed by the antigen-presenting cell, which are the immature macrophages or dendritic cells. They process them through the toll-like receptors, and this is really important because this is going to be one of the mainstay treatments in lupus. And once they get processed by the antigen-presenting cells, then they go to the lymph node and present them to a naive T cell helper. So in the naive T cell helper in the lymph node then gets activated with the interleukin-4, and this is where you can also think that this is going to be another of the different mechanisms for treatment of SLE. And what happens is that the interleukin-4 promotes the T helper cell into converting into T helper 2. And the T helper 2, what it does is that it activates the humoral immune system. And the humoral immune system is the one that takes care of producing immunoglobulins and antibodies. So then the T helper T2 cell goes and presents to and interacts with the B cell. And once the B cell and the T cell have interacted, what happens is an activation of it, and it converts into a plasmacyte. Once the plasmacyte is active, what it does is that depending on the antigen that was presented, and this is important because if you see here, depending on the part of the cell that was actually presented, you will develop the antibodies against these different parts. And this is where you actually get the picture of the autoantibodies. So from the nuclear proteins that present as antigens are going to be the histones. So this is where you get the antibodies against the histones, double-stranded DNA, and the different ribonuclear proteins complexes like Smith or U1RNP or the Rho SSA. But the Rho and SSA is not only on the nucleus, it's also going to be in the cytoplasm. So you're also going to see it there. And then parts of the cell membrane itself can actually get exposed. And this is why some people develop cytopenias. Because these parts of the cell membranes, the red blood cells or the platelets, can actually be presented as antigens, and the cardiolipins is also part of the cell membrane. So going back to the part that I was explaining about, that you get the development of antibodies. So the antibody can actually go and then attack your own cells because they were presented as a weird organism. So that's where everything starts. So the other thing that can happen once there's interaction in between immune cells and the antibodies is that you start having inflammation and you start developing cytokines like interferon 1 or TNF alpha. And this is also important because this is targeted therapies for lupus as well. Then you have a lot of immune complex deposition. The immune complex, once it interacts with the target cells, it creates complement activation. And once you have the antibodies, what happens is that you have the antigen around and it starts getting exposed again to the other cells, cells starts getting damaged, and it's just a cascade of inflammation. So once you have the interaction between the antibodies and the other immune cells, there's more production of cytokines that promote the proliferation of B cells. And this is gone through interleukin 6, interleukin 10, BLyS and BAFF, which are related to the B lymphocytes. One is a stimulator and the other one is an activation factor. So then you can see that it's just promoting inflammation continuously. And I wish it would stay just like this, but the mechanisms behind the flare-ups is the fact that these plasmocytes, some of them actually look long-term on the bone marrow. And once they're there, what happens is if you have another environmental factor that causes cell damage, you can have the same immune response that you had as the first time. But why is it that some people get it and some other people don't? And this is where it all plays out. So there are certain people that have a genetic predisposition or maybe an epigenetic phenomenon that puts them at risk, but then you get any of this environmental exposure or even infections from viruses that will activate your immune system, and then it states just a continuous inflammatory response. So the clinical manifestations of the disease of 1,000 faces is, you name the organ, is going to be affected. So first, starting with neurologic, there can be seizures, but there also can be neuropsychiatric symptoms. These patients are actually also predisposed to have strokes. Here, I'm just gonna put it as an outline, but see that even fever. So this is complicated, the fact, because there are a lot of other diseases that are gonna look a lot like lupus. So it's always better to have this on the back of our mind whenever you are seeing that these patients are having several different manifestations that can be explained by it. So let's go into details. What do you guys think are the most common manifestations of lupus? If you see of all of this, what are the most common ones that you're gonna see?
Rashes.
Skin, definitely, and the other one?
Arthritis.
Joints, right? So musculoskeletal and skin. So internists, we are really good at dermatologic manifestations, right? So pictures. Let's get to pictures. So mucocutaneous manifestations, the most common one would be the acute cutaneous lupus erythematosus rash, which is the rash or the butterfly rash on sun exposure areas. But know that there are other manifestations like the subacute one, and it tends to avoid the central area of the face. Besides from that, we can see discoid lupus and areas of alopecia in the hair, but this can also happen in the face itself. And then other things that we need to know that to look out for is that patients may develop mucositis. So it's good to have a good physical examination once we're thinking about this on a patient. And musculoskeletal manifestations, arthritis, arthralgias, and this is one of the manifestations called Charcot arthropathy, which is a subluxation, but also with ulnar deviation, and it's seen on patients with lupus. Something that is a not to miss diagnosis in patients with lupus is that they are at risk of developing osteonecrosis of the hip, and it's important, especially if they have sustained therapy with corticoids for such a long time. Okay, can somebody tell me who this guy is? Come on, guys. Somebody needs to be as old as me and into celebrities. It's Seal. He is a singer, and he used to be married to Heidi Klum. So he actually developed at a very young age discoid lupus, and it actually healed up like this. So he's one of the celebrities that promotes a lot of awareness on lupus. She's on another picture, don't worry about it. Okay, so then we're going with all of the other organs. One of the main important ones is cardiovascular. So we hear about Liebman and endocarditis, but there's also valvulopathies, myocarditis, pericardial effusion, pericarditis itself. But the mainstay to remember is that these patients are going to be at an increased risk of cardiovascular disease. So this needs also to be into consideration whenever we're assessing these patients. Like I talked on the previous slide, these patients are going to be at risk of strokes as well, and seizures. And you know, the pathogenesis of lupus actually was the best described one once we got to know about the different types of lupus nephritis. So proteinuria on a patient that you're suspecting lupus is something very important. And something that gets missed sometimes is GI manifestations, serositis, autoimmune hepatitis. These are things that happen in patients with lupus, but we don't think about it. And since you develop the autoantibodies against the cell membranes, the anticardiolipins, and also the membrane of the red blood cells and the platelets, you can have the cytopenias as well. And as Harsh was mentioning,
So Selena Gomez has been dealing with SLE, and she actually got diagnosed with rapidly progressive lupus nephritis, and she actually required to have a renal transplant.
Oh, I thought that was thickness.
There's no scars. I don't know. Okay, so I'm just so we can keep it a little bit interesting. I'm gonna ask you guys a question. Can you read it?
A 26-year-old woman is evaluated for a 3-month history of increasing left hip pain that is worse with prolonged standing. SLE was diagnosed 5 years ago, characterized by small joint arthralgia, malar rash, cytopenias, and a Raynaud phenomenon. At diagnosis, she required high-dose prednisone, hydroxychloroquine, and azathioprine therapy. Prednisone dosage was tapered over 6 months. Periodic flares have been treated and increased dosages of prednisone. Current medications are hydroxychloroquine, azathioprine, and low-dose prednisone. On physical exam, internal rotation and flexion of the hip are limited and elicit pain. The remainder of the exam is normal. Complete blood count, ESR rate, and serum complement levels are normal. Anti-double-stranded DNA antibody titers is low and has been unchanged for 6 months. Radiograph of the left hip is normal.
Okay, guys. So, which of the following is the most appropriate management? Do you guys think that we should change her from azathioprine to mycophenolate? Should we increase further the dose of prednisone? Should we get an MRI of the hip, or should we get her to have physical therapy, and why? So, what do you guys think that she's dealing with?
So right now she's currently stable, the complex and the CNR factors levels are not that high numbers.
So what is the one not to misdiagnosis on these patients that are dealing with SLE, start having hip pain and are exposed to osteonecrosis of the hip? And how do you diagnose that? An MRI of the hip. Okay, good. So there have been lots of different classifications that you use actually to help yourself diagnose these patients. And they have been changing time to time, but it's pretty heavy to memorize all of this. So in 2019, there was a change to the one that we actually use, which is the EULAR from the European League Against Rheumatism, which is a cool name, and then the American College of Rheumatology. What they said is that now, in order for us to diagnose lupus, you need to have at least one titer, 1 in 80 or more, at least in a lifetime. And remember that this wasn't actually meant to be used for the diagnosis of the patient. It was mainly to have a homogeneous population of people once you were doing studies on people with SLE. But since this is something that it makes it more uniform, it's one of the ones being used for making the diagnosis. So once you have this, then you go to look for the other manifestations, and you need to have at least 10 points. So things that I want you guys to look at is that fever, and making sure that it cannot be explained by any other manifestations, then the different cytopenias, the neuropsychiatric disorders. But the ones that give you a more amount of points are going to be if you have renal involvement and already a positive biopsy for the different types of lupus nephritis, either 3 or 4. And then if you have antiphospholipids, if you have 1, it's going to be same 2 points. It's not going to be that if you have the 3 antiphospholipid antibodies, that is going to be 6 points. It's just 2 points. Either if you get more points from having both of the complements low rather than having just 1. And then the other ones that are more specific for lupus would be anti-Smith and the anti-double-stranded DNA, and that would give you 6 points. And remember that this sometimes is diagnosed throughout the whole patient's life. Okay, so the cool thing about this slide is that we already covered it in my wannabe art on the pathogenesis. So basically, if you see all of these ones here are the ones that are based on the antigens of the nucleus, and then you get antibodies produced against them. So the antinuclear are the ones that are more sensitive, and that's why we use them to have a cutoff criteria to say, okay, let's investigate these patients further for SLE. The anti-double-stranded DNA and the anti-Smith are associated with severity of disease.
The anti-Ro is not only on the nucleus, it also can be on the cytoplasm. And it's important because you can also see them as Sjogren, and it's heavily associated with patients with lupus, neonatal lupus. The anti-U1 ribonucleotide protein is actually associated to Raynaud phenomenon. That is one of the other phenomena that is commonly seen, especially on SLE patients, and is one that is described as a mucocutaneous manifestations as well. The anti-La with anti-Ro is another one that is associated with patients with neonatal lupus, and then further development of heart block. And the anti-ribosomal P is associated more with CNS manifestations of lupus and lupus erythematosus. Okay, so challenging thing about lupus is making a good diagnosis, but also seeing the other differential diagnosis that may be looking a lot like it. So there are a lot of medications that can induce you a syndrome that looks a lot like lupus, but the thing is that it's very unlikely that you're going to see a very severe case with it. Most of the time it's going to be patients with fever, rash, arthralgias, malaise, and this should always ring a bell in your brain saying to look out if the patient's taking any of these medications, because the cool thing is that if you actually discontinue these medications, patients actually get better. So I think the ones that we know more about are procainamide and hydralazine, but things are like minocycline, patients that are being treated sometimes for acne, things like this, antithyroid drugs, the statins, calcium channel blockers, which are medications that we use on our day-to-day, ACE inhibitors, and then if you see here, part of the treatment can also induce drug-induced lupus erythematosus. So how do you monitor these patients? It's really hard keeping up with all of the symptoms, so they have created an index of severity and activity just to monitor if patients are doing better on therapy or not, and this is an objective way of characterizing it. And then the more points you get is the more active the disease is. Okay. Let's see over here. Then management. So management of the disease is going to be, the goal is going to be that the patient has achieves clinical remission, but also sometimes it's going to be very hard for patients to achieve clinical remission, so you want to have them at a lower disease activity as possible. So how do you do this? The mainstay treatment, and I told you guys to remember about the toll-like receptors, is because hydroxychloroquine actually acts there. So this is the mainstay of treatment in patients with lupus, and you try to place all of your patients on these medications if it's tolerated. Do you guys know what are the things that we'll need to be on the lookout for if a patient's on hydroxychloroquine? Okay.
Check the eye.
Okay, yeah, definitely. So the not to miss here is that these patients, after being started 5 years on treatment, you need to have retinal checkups just to see if there's no retinal toxicity from it, okay? And then the other thing that we commonly see in these patients is that they're started on steroids. So steroids are really good, they're gonna treat the disease, but the problem is that they're not innocuous. They have their own problems coming up with them. And like we see, patients that are on heavy doses of steroids then have a higher risk of developing osteonecrosis of the hip. So it's true, you see the severity of the disease, and then you will want to get them to be at the lower disease activity with the lower amount of steroids as possible. So when I say severity of the disease is that if a patient's having CNS manifestation like neuropsychiatric symptoms or lupus nephritis, or if the patient's having like severe cytopenias, these are patients that you're looking out on giving them high doses of steroids. Which are the patients that we're going to be looking out on giving them IV high doses of steroids? They're going to be the patients with type 3 or type 4 lupus nephritis that are very hard to control on the other different medications, but also patients that have seizures. So these are going to be the two main indications for IV high doses of steroids in patients with lupus. And then there are other immune modulating medications like mycophenolate, which is one of the ones used for moderate to severe disease, especially with lupus nephritis. And cyclophosphamide is another one that you can also use, especially if there's severe organ damage from lupus. Belimumab. So you guys remember how we're talking about the BLIS and the BAF? So this is going to be one of the targeted therapies. And besides from that, azathioprine is also used to moderate to severe disease. And this is one of the immune modulating medications that we can actually use during pregnancy. So do we only treat these patients and that's about it? There's a lot more to do with lupus patients that we can recommend. So first of all, making sure that patients have adequate intake of vitamin D. And sometimes you have to remind them to be wary of the sun, avoid sun exposure, and even if they're not out of the sun, they need to be wearing sunblock. Remember bone health. A lot of these patients are exposed in their lifetime to a lot of prednisone and corticosteroids. So if needed, a DEXA scan is necessary. So we talked about briefly how these patients have an increased cardiovascular risk. And once you have the increased cardiovascular risk, depending on how severe it is, what you do is risk modifications, treating hypertension and treating hyperlipidemia. That's why it says there's statins and antihypertensives to reduce cardiovascular risk if necessary. And if the patients are at risk of having, if they're developing hypertension as well, an ACE inhibitor should be used. So another thing that we get a lot is the questions about lupus and pregnancy. So the thing about lupus and pregnancy is you have a 5 to 8-fold increased risk of miscarriages and stillbirth, but also even if you get to the final stages of gestation, you have high risk of intrauterine growth retardation. So they have seen that babies of moms that are positive with anti-Ro and anti-La are at higher risk of developing neonatal lupus. And once you have already neonatal lupus, you have a 20% risk of developing complete heart block. So what do you tell the moms? So normally you would tell them, you know, if you want to planificate your pregnancy, the best thing is to have your disease well controlled for 6 months at least, and then start planning your pregnancy. And what do we use on these patients? Normally hydroxychloroquine, and then if patients have flare-up, you use then low-dose glucocorticoids. But if the disease is fairly severe, then you would go on and give them azathioprine as well. Okay guys, so we are almost at the end of the presentation, and I have a couple of questions for you.
Can you read? A 30-year-old woman is seen in follow-up. She was diagnosed with SLE 12 years ago. She was treated for lupus nephritis, which is now clinical and laboratory findings have been stable for 5 years with no disease flares. Medications are hydrochloroquine and azathioprine. Which of the following health risk assessments should be performed now?
Okay, so you have a 30-year-old that we already know that she has SLE. She's been dealing with it for quite some time. She was treated for lupus nephritis, and apparently she has been stable for the past 5 years, and she's only taking hydroxychloroquine and azathioprine. She's 30. So is she at increase of breast cancer, cardiovascular disease, pulmonary disease, iron overload? What do you guys think? Yeah, definitely. And how would you assess cardiovascular risk in her? So basic things, right? A measurement of blood pressure, measurement, exactly. Okay. So next question. Can you read, please?
An 18-year-old woman is evaluated for a 1-week history of fever and diffuse myalgia and pain and swelling in the hands and knees that have progressed over the last month. She also has acne. Current medications are minocycline, topical tretinoin, and oral contraceptive. On physical examination, temperature is 38.3 degrees Celsius. Other vital signs are normal. She has synovitis in her hands and wrists and inflammatory acne on the face and upper back. Test results for antihistone and other specific autoantibodies are negative, and serum complement levels are normal. Which of the following is the most likely diagnosis?
So if you see here, one of the keys to this question is that